but ultimately it's subjective. Some people will differ in terms of their what we call pain tolerance, whatever that means. And really, it's just going to be based on what the patient describes what they're feeling as. One of the taglines is it's pain is whatever the patient says it is. What we can do is break down pain in a number of different categories. One is based on its chronicity, acute pain versus chronic pain. Acute pain is typically the result of a tissue injury, and the response within minutes to hours to days thereafter, whereas chronic pain is measured really in months to years. We could also break down pain as to whether it's from a malignant origin or non-malignant, based on whether cancer is involved or other progressive diseases. And then we can break down pain in terms of its etiology, whether it's nociceptive from tissue injury somatically or viscerally, or neuropathic pain from nerve damage. So the acute versus chronic dichotomy is here. Again, acute pain is shorter term, hours to weeks. Chronic pain, we measure in months to years. Acute pain is from some sort of injury to tissue, such as from trauma or a medical procedure or surgery, and will typically have a predictable prognosis as that injury resolves. The associated pain will fade away, and we can use analgesics for acute pain to provide some relief. Chronic pain, on the other hand, really does not have a well-defined endpoint that we can necessarily point to. And in those individuals, we will use analgesics, but very often we'll try to use other modes of pain relief as well, be it chiropractic or acupuncture, physical therapy, various other approaches so that we can preserve quality of life in those patients. The nociceptive neuropathic dichotomy is here. Nociceptive is further broken down into somatic versus visceral. Somatic basically from injury to skin, bones, joints, or muscles and connective tissue, whereas visceral we think of as from the inside. These are your internal organs that may project pain to various parts of the body. And this is described as sharp or dull and aching or throbbing in nature. Whereas neuropathic pain is caused by nerve damage, and it is localized along a nerve tract. So you will get a shooting or burning, tingling experience localized in those areas where the nerve damage is occurring. So here again is just a review of the various etiologies comparing somatic, visceral, and neuropathic. Note that visceral pain can be referred to somatic structures from the inside out to somatic structures. For example, in a MI, we think of the pain radiating down the arm, for example. So that is an example where that referred pain occurs. And neuropathic pain, of course, is along that nerve tract where the nerve damage is taking place. So in the case of an acute pain, we talk about this arc from the periphery to the central nervous system and back. We can use an example of, say, you stub your toe. You're at home and you maybe trip over something or kick something accidentally. There is the sensory communication from the periphery, okay, So you have nociceptors. These are receptors in the skin that will be sensitive to pressure, to chemical stimuli, to heat or cold, and other mechanical stimuli. So that receptor gets activated when you stub your toe, sends a signal. This is an ascending signal from the periphery up through the spinal cord and into the brain. And that's where you process the stimulus. So you have a reaction which involves a communication back from the brain that will send a pain signal. So that sensation of pain occurs after the brain processes that injury and sends it back. You also have, you see the limbic structures here are involved. Think of emotions. We said it's not just a sensory, but there's an emotional component. So you stub your toe, you get mad, you want to curse. That is the limbic system being activated there. So you have your somatic communication descending that will process that or will be the result of that pain signal. And then the emotional component from the limbic structures in the brain. Now, you also have inhibitory pathways. So it's not as if that pain that you're feeling from stubbing your toe will be there forever. You will eventually activate inhibitory pathways from the brain back to the periphery. And that involves a number of transmitters here in the spinal cord. So this section is kind of zoomed out here in this diagram. And as you can see, serotonin, norepinephrine, ENK, this stands for enkephalins. Enkephalins are part of a family of what we call endogenous opioids. Okay, they also have inhibitory activity on pain. And all of these will serve to kind of attenuate, to shut down the pain response over time. You have fast fibers, the A delta and C fiber, or A delta fibers for fast, and then C fibers are for slow transmission. So they have different responses. The fast response obviously is to protect you from further injury. So if you touch something hot, that fast transmission will cause you to quickly withdraw your hand from the hot stimulus. And then the ongoing kind of dull burning that you get from that is your way of saying, okay, you are now learning not to touch something hot again. That is going to be a long-term thing that etches in your memory. So that's why you have your fast and slow fibers for pain transmission. And then again, the descending fibers activate your endogenous opioids. So that is the kind of the somatic pain pathway. Now, we'll give a second example of inflammatory pain. So here, we're talking about the effects of, see a question. Would you like to ask, Abel?
Yeah, so I don't need an answer if it's not important for the class, but I see that on the descending pathways, there's that box that says activated by opioid analgesics. Is it saying like all of these pathways are just affected by opioids and that's all we need to know, or what is it trying to tell us?
Okay, so these are inhibitory pathways that will reduce the activity of the pain production. So it's kind of an activation of pain inhibition. So opioids, of course, are drugs that are analgesics. They reduce pain. And you have endogenous opioids. So you have a whole system, and we'll talk about in a couple of slides, of chemicals in your body that work like morphine or whatever, but they're your own body chemicals that will inhibit pain. So before we talk about drugs, this is just kind of how your own body responds to block over time the pain response after an injury. So that is what it means by activation of opioid analgesics. The example, though, right now, before we talk about drugs, is enkephalin, okay, which I'm pointing out here, and that is an endogenous opioid. That's a chemical that you make yourself that will serve to block the pain response. Okay. So the second example of pain I'd like to present would be, say, an insect bite. Okay, you get a bee sting or a mosquito bite that produces inflammation. All right. So of course, the actual trauma of the insect bite itself will kind of produce a pathway like this, right? Because you get, the mechanical stimulus of the insect literally biting you, and you get the pain response from that. But there's also an inflammatory component. When you get, say in a mosquito bite, they kind of put their saliva in your body or whatever, and that produces an inflammatory response. And that also can trigger a painful sensation. All right, so it's separate from the actual trauma of the bite, but you're also now having your own body producing an inflammatory response to the kind of the foreign chemical that's being introduced into the body from the insect bite. So you have the trauma and chemical irritant, foreign protein. All of those would be applicable here in the case of an insect bite. And what happens is that you produce an inflammatory response. So we've talked about this in this class, and I'm sure in some of your other coursework, where inflammation can lead to an entire cascade of release of various chemicals. So here we're talking histamine. You recall histamine, of course, having an important role in allergic reactions, bradykinins, prostaglandins, leukotrienes. And basically, this whole cascade takes place until you get to prostaglandins and leukotrienes that will decrease the firing threshold of pain fibers, which means you have a lower threshold, you have a lower, basically a lower amount of stimulus that would then cause those pain fibers to be fired, which means they're more likely to fire. And when you get inflammation, basically it's saying inflammation will lead to pain via the activation of all of these pathways. So again, prostaglandins, leukotrienes, this substance P is relevant for one of the drugs we'll be talking about. So all of these inflammatory mediators also can relate to pain, etiology of pain. And again, this is from, say, acute conditions like an insect bite, or we could think of this as for more chronic forms of inflammation, such as rheumatoid arthritis. All right, we'll talk about that later in the semester. But basically, these ongoing chronic or acute inflammations can cause a painful response. And then this is a diagram of how these inflammatory mediators are produced. All right. Basically, several of them are derived from a common chemical called arachidonic acid. Arachidonic acid is derived from the cell membrane phospholipids. And arachidonic acid will yield, through various reactions, leukotrienes, thromboxanes, and prostaglandins I2, E2, and F2. The enzyme that leads to production of the thromboxanes and prostaglandins is called COX, cyclooxygenase. Cyclooxygenase is the pharmacologic target of a class of drugs we'll be talking about today, which are the NSAIDs. And then you have 5-lipoxygenase, which catalyzes conversion of arachidonic acid to leukotrienes. Now, we talked about this pathway last semester when we covered oral drugs for asthma. You may remember xylutone, montelukast, and zopirolacast. These are drugs that we use to treat asthma. They're given by mouth, and they are leukotriene antagonists and leukotriene or 5-lipoxygenase inhibitors in the case of xylutone. All right. So this pathway obviously is going to be relevant for inflammatory respiratory diseases. All right. And note that it is not affected by COX. All right, because it's a separate pathway from the COX drugs. But going down this pathway here, NSAIDs will block the conversion of arachidonic acid into thromboxanes. Thromboxanes are active in the platelets, and thereby this pathway will produce platelet aggregation. This is a good thing in tissue injury because if you have, say, a contusion or a bruise or a cut or some other tissue injury, obviously platelet aggregation would help prevent severe bleeding. All right. Drugs that block the conversion of arachidonic acid into thromboxanes will serve as antiplatelet drugs. Again, think back to last semester. We talked about antiplatelets, specifically aspirin, which irreversibly blocks platelet aggregation, and therefore it makes it helpful for stroke prevention. All right, this pathway is also relevant for prostaglandins in the endothelium. Endothelial lining of blood vessels tends to remain open while in the presence of prostacyclin and kind of contracts when this is inhibited. One of the side effects of NSAIDs is kind of closure of these blood vessels, which, for example, makes it a problem for kidneys, for the kidneys that rely on that circulation. So part of the renal effects is from blockade of prostacyclin in the vessels that lead to the kidney. And then we have prostaglandins in the smooth muscle E2, F2. Some of the activities of these prostaglandins relate to uterine contraction, relate to some of the protective lining in the GI tract. Again, think back to last semester. Some of the NSAID-induced ulcers we talked about are from, again, inhibition of these prostaglandins. So this diagram really does a lot to kind of help explain the toxicities of NSAIDs, which we'll cover, but then also how arachidonic acid relates to respiratory disease in the case of the lipoxygenase pathway. Okay, if you didn't get that all at once, that's okay. I have some more explanations as we go forward, but this is kind of a way to kind of set the stage for our discussion around NSAIDs. But with all of that being said, we'll start with, here are the cyclooxygenase isozymes. So cyclooxygenase has obviously important roles in kind of maintenance of, say, the GI stomach lining and the patency of arteries. So you have that, and then you have kind of a response to inflammation. So there are actually two separate enzymes that serve those functions. COX-1 is considered the constitutive or housekeeping enzyme. This is the enzyme that is kind of just a baseline level of cyclooxygenase functioning that's helpful for homeostasis, keeping things normal, keeping your circulation regulated, your stomach lining, your smooth muscle. This is just kind of an important enzyme for general cytoprotection in the GI tract and throughout the body. There's also a second enzyme, COX-2, which is only upregulated in the event of an inflammatory process or injury. So COX-2 is inducible, COX-1 is your constitutive. It's just always active. When we want to kind of deal with the effects of tissue injury and reduce inflammation, COX-2 is what we're after. All right. So this enzyme will be active after tissue injury. It's involved in the inflammatory process, and obviously pain generation, inflammation, etc. Now there has also been isolated a third enzyme called COX-3. We think that acetaminophen, which is an analgesic drug, may work on this particular enzyme, but other than that, there's not a lot of that is known about COX-3. Right, so with that, we'll start with acetaminophen. I'd be surprised if anyone on this call is not familiar with this drug. Basically, its brand name is Tylenol. It's abbreviated as APAP. You may see that abbreviation that basically comes from its chemical name, acetyl para-aminophenol, APAP, or the brand name Tylenol, which is also derived from that chemical name. So as you know, Tylenol is an analgesic, antipyretic, so we use it for pain and fever, but it is not really an effective anti-inflammatory. So we do not really see a lot of role for it for reducing swelling and treating inflammatory conditions. So it's great for moderate pain and fever. Osteoarthritis, which tends to be a non-inflammatory condition, will respond well to Tylenol. And then in terms of more severe pain, you can use Tylenol with opioids. And indeed, there are a lot of preparations which combine the Tylenol and opioids, such as Vicodin, etc., which we'll talk about. We'll talk about Tylenol's hepatic metabolism in the next slide, but really side effects in therapeutic doses are minimal. You can get some renal dysfunction, but in toxicity is where we're concerned. The threshold for acetaminophen toxicity is 3 grams per day. They used to teach us 4 grams, but really the modern thinking now is that 3 grams a day of acetaminophen is where you can run into problems with toxicity. And again, I'll cover on the next slide. And then in terms of its availability, the most common dosage form is the oral tablets, but you can also see liquids. You can give it as a suppository. Again, combined with opioids and products such as Vicodin, Tylenol, number 3. And then there is an IV formulation that's used in surgical settings for post-op pain management or if patients cannot tolerate oral PR. Question?
Do we consider acetaminophen as part of treating just acute pain?
That's a good question. For chronic pain, chronic pain is, let me put it this way. Chronic pain, again, is multimodal. And even within pharmacologic treatment for chronic pain, you may end up using combinations of drugs and things of that nature. So, again, not to jump too far ahead, but you will often in chronic pain have a basal regimen, say kind of a long-acting drug, either an anti-epileptic drug for neuropathic pain or a long-acting opioid or something of that nature. And then there is breakthrough pain. Breakthrough pain within the context of chronic pain means is that you can have an episode where you kind of have a long-acting drug to manage the ongoing pain, but for some reason, you get a sharp breakthrough pain. I'm sure you know what that term means. So in those settings, yes, it may be helpful to use kind of as needed Tylenol or Vicodin or whatever for breakthrough. The other instance where Tylenol for chronic pain makes sense is osteoarthritis, where, again, it's not an inflammatory condition, and then you cover this later in the semester as well, but you're giving kind of scheduled Tylenol, 650 milligrams 3 times a day, just to manage the ongoing pain associated with osteoarthritis or some other condition. But outside of that, and Professor Newman, if you think of other examples, outside of that, we don't really think of Tylenol more for chronic pain. It's more for acute pain. But there are some instances, for example, like I said, breakthrough pain and osteoarthritis, where it makes sense to use Tylenol more chronically. All right. Metabolism and hepatotoxicity. So again, acetaminophen, really safe drug within therapeutic doses. But one of the most common overdoses is from Tylenol. And that is explained here. So when you take acetaminophen, you have kind of a phase 2 pathway and a phase 1 pathway for it to be broken down. Again, think back to last semester, we talked about drug metabolism. Phase 2 is when you conjugate, you take a large molecule, you stick it onto the drug, and then it typically inactivates it and prepares it for renal elimination. In this case, the conjugation of acetaminophen, either with sulfate or glucuronide, leads to its renal excretion. All right, easy peasy. That is the perfectly safe, perfectly normal way that most of your acetaminophen gets cleared from the body. However, there's also a minor pathway, which is a phase 1 P450 catalyzed pathway, where acetaminophen is oxidized to a toxic intermediate, and that is called NAPQI, all right, N-acetyl P-benzoquinone imine. Even this toxic intermediate can be cleared from the body, again, without much incident, at normal therapeutic doses if you have enough of a chemical called glutathione in your liver. Glutathione will serve to take this toxic phase 1 metabolite of acetaminophen and clear it from the body. Now, when you overcome this, you have too much acetaminophen on board, that the conjugation pathway is overwhelmed and your glutathione conjugation pathway is overwhelmed, then you get this NAPQI toxic intermediate, which then wreaks all sorts of havoc on the liver, leading to hepatic necrosis. Again, we think that at doses greater than 3 milligrams a day, either in a single overdose or cumulatively over the course of a day, increases the risk for this liver damage from this toxic metabolite. Right? So, how do we deal with that? There is, again, just as a reminder, when you saturate the phase 2 glucuronidation and sulfation and deplete glutathione, now we're in the situation of acetaminophen hepatotoxicity. It presents with GI upset, LFT elevations, hypothrombonemia, and as it progresses, you get into metabolic acidosis, hypoglycemia, because your liver is damaged. You're not now able to break down the glycogen, so your sugar drops. Hepatic encephalopathy, and eventually can be fatal. So we manage this through there's an antidote, basically acetylcysteine, which is a substitute for glutathione, which we can give to patients when they present with Tylenol toxicity. Again, this is the most common overdose that's encountered in medicine. So, there's often protocols in hospitals that deal with this, but there's something called the Rumac Matthew nomogram, which is often programmed into the electronic medical records of certain hospitals that deal with this, and will kind of guide you as to how to dose the acetylcysteine based on the blood level of Tylenol that the patient is presenting with, and your best estimate of how long it's been since the patient ingested the overdose. All right. So if they have a blood level of 40, acetaminophen 16 hours post ingestion, you see that they're well within the point where they are to receive the acetylcysteine, and then that acetylcysteine is then based on the patient's weight, etc. But basically, that is the nomogram for acetaminophen overdose. All right. As we kind of go through pharmacology, we don't get to talk a lot about toxicology, but that's obviously a discipline within pharmacology, and really the common overdoses. We talked about last semester, for example, opioid overdose and how to reverse that. We'll talk a little bit about aspirin overdose. So these are things that are helpful to kind of have a knowledge about. We don't get to cover everything in depth. And as clinicians, I think a really good resource, for example, you might be working in a rural ER and you get a patient come in with some weird overdose, and you don't have a lot of folks that can help you in that situation. But if you are familiar with the Poison Center, they are going to be a life-saving resource for you and your patients. They are accessible 24 hours a day. You can call 1-800-222-1222. That's to get, if you're practicing in Maryland, that will put you to the Maryland Poison Center. But if you're in another state, that same phone number gets you to any of the local poison centers that will be covering the area that you're practicing in. And they obviously will, they have clinicians that they're experts in toxicology that can kind of talk you through managing patients with, kind of weird overdoses. So that is going to be a helpful resource for many of you working in acute care where you're seeing patients with overdoses. It can be, overdoses like acetaminophen. It could be like a snake envenomation where you kind of have to mobilize resources to get antivenin in or whatever. So the Poison Center is a great resource for that. All right, so that's an aside, but that is Tylenol toxicity. Just wanted you to know about that. All right, NSAIDs. So these are drugs that do inhibit COX enzymes. Most of them inhibit both COX-1 and COX-2 to some degree. And they are broken into a number of chemical classes based on their chemical structures, which I will kind of present over the next few slides. Starting with salicylates. We'll start with the class effects first. The class effects for NSAIDs, these are going to be common across the group of NSAID drugs. GI. Again, by inhibiting the constitutive COX-1 enzyme, You will reduce some of the protective lining of that the prostaglandins provide in the GI tract. And you will also have some local effects. So when the drug is in contact with the GI lining, you can get dyspepsia, nausea, vomiting, and then over time that can lead to ulceration from decreased mucus production. Again, we talked about their effects on thromboxanes, so you get a decrease in platelet aggregation, thrombocytopenia, and bleeding. The worst is from aspirin, because aspirin irreversibly acetylates the enzymes involved, whereas most other NSAIDs are reversible, so it's not as notable for other NSAIDs. You can get allergic reactions. Some patients develop rashes or anaphylaxis to certain NSAIDs. During gestation, you can have, because of their effects on smooth muscle, they don't allow for uterine contraction to take place. So you get a prolonged gestation and late pregnancy. You also have a teratogenic effect called a PDA, patent ductus arteriosus, which is involved in the heart circulation, where oxygenated and non-oxygenated blood is allowed to mix in the heart. That could be a problematic issue in the newborn. Asthma and bronchospasm could be worsened with NSAID use. Okay, let's kind of look back here. So, if we are blocking this pathway from arachidonic acid, in effect, we're actually promoting more conversion of arachidonic acid into these leukotrienes. So really, it shouldn't be too surprising that NSAIDs can actually worsen effects of asthma and other inflammatory diseases of the respiratory tract, because although we're not necessarily accelerating leukotriene production, we're basically kind of tipping the scale more towards this direction if we are blocking COX, right? So that is the explanation for the bronchospasm in asthmatic patients. Also, these drugs can cause hepatic side effects by increasing liver enzymes, and their effects on the renal vasculature, which I explained earlier, can lead to decreased renal function. All right, so the first group of NSAIDs are the salicylates. The prototype drug, of course, is aspirin, acetyl salicylic acid, or ASA. This drug, although we don't use it for pain per se, has some very potent antiplatelet effects at low doses, and really is a key drug for cardiovascular disease. Diflunisal and salicylate, older NSAIDs we don't use much, but they're out there. And then salicylic acid we actually use more topically as an anti-inflammatory, for example, for acne. So as with all NSAIDs, they exert analgesic and anti-inflammatory effects, antipyretic effects, and probably amongst the most significant antiplatelet effects of all the NSAIDs. Again, aspirin is irreversible, COX inhibition, and these are safe for patients with cardiovascular and ischemic heart disease. Again, we talked about aspirin last semester, and I think we mentioned that low-dose baby aspirin, although it's marketed as such, it's really not for kids because of the association with Rye syndrome, which I'll talk about in a second. Yeah, this is fairly straightforward kinetics. The only thing with aspirin that kind of makes it more complex in its use is that its dynamic effects are much longer than you would expect based on its kinetics because of its irreversible activity on the COX enzyme. Here is the dose response curve for aspirin at low doses. The baby aspirin dose, for example, is 81 milligrams. It exerts antiplatelet effects. We can see analgesic effects. Again, we don't use it a lot for pain, but at around 650 milligrams, it exerts analgesic effects. 3 to 6 grams anti-inflammatory effects, but then you get into some of the side effects, tinnitus, ringing in the ears, start at that dose. And as you exceed 6 grams, you're getting into more unacceptable toxicities. And again, a very severe aspirin overdose can lead to death and other effects as you progress. So again, most of the time we're using aspirin is going to be for its low dose antiplatelet effects. Here's a word about Rye syndrome. Occurs with salicylate exposure in children. Okay, so it's not all NSAIDs, it's just the salicylates. We talked about aspirin and diflunisal, those other salicylates. And then last semester we also covered Pepto-Bismol, which is bismuth subsalicylate. That's another salicylating agent. So basically we should be avoiding salicylates in children because of this particular effect, the fatty liver encephalopathy that has about a 50% mortality. All right, next group of NSAIDs are the propionic acid derivatives. They have the PRO in their generic name, ibuprofen, naproxen, and ketoprofen. They all happen to be available as over-the-counter drugs, so obviously very widely used, relatively safe in therapeutic doses. These NSAIDs are reversible, non-selective inhibitors of COX, and obviously are absorbed orally. There is an IV version of ibuprofen, again, used more in surgical situations. They're great analgesics. We can use them chronically for arthritis. But again, the longer you have high doses of these drugs on board, especially in older patients, the greater the risk for GI ulceration and such. Less severe GI effects compared to, say, some of the other more potent NSAIDs like indomethacin, for example. But you can have more renal hepatic toxicity. And typically with ibuprofen, we give on a Q6 to Q8 hour regimen, whereas naproxen has a longer half-life, suitable more for BID dosing. Right. And then some of these other NSAIDs are in the acetic acid derivative chemical class. The actual chemical class is not as important as really just some of the key features of some of these drugs. For example, indomethacin is a very potent COX inhibitor. We do not use this except for moderate to severe inflammatory conditions. Diclofenac, you may see over the counter as a topical gel, Voltaren gel, that's used to treat local inflammation. Oradol ketorolac, very commonly used drugs in emergency and inpatient settings. Much more commonly used the injectable formulation for severe acute pain. But we try not to give it for more than 5 days because it has a very high risk of GI bleeding and seizures. Nubumeton relevant we use long-term for arthritis. Has some COX-2 selectivity, but it's not considered a COX-2 specific agent. And then Solindac, Clinaril, older NSAID, but we do have some advantages on that. It does not have the same toxicities on the renal prostaglandins. In the enolic acid class, you have meloxicam. Again, a little bit more preferential for COX-2, so it's better GI tolerability than most of the other NSAIDs. And piroxicam, which another older agent, fairly long half-life, so once a day, good for chronic use, for example, in arthritis. And then the COX-2 inhibitors actually used to be a class of drugs. At one point, there were 3 marketed COX-2 inhibitors, which included celecoxib, Celebrex, which is still on the market, rofecoxib, and valdecoxib. But those latter 2 have since been removed from the market because they actually been shown to have increased incidence of bad cardiovascular outcomes, heart attacks and strokes. But in theory, the advantage of COX-2 inhibitors is that they are selective and reversible inhibitors of the inducible enzyme COX-2. So that would target pain and inflammation without, in theory, affecting, in particular, the GI prostaglandins that's involved in the protective effects on the stomach lining. And in practice, that is true. We see less GI ulceration with Celebrex than with other NSAIDs. And so that makes it suitable for long-term use. The renal toxicities, however, are still comparable to other NSAIDs. Right, so that is Celebrex. Any questions on the NSAIDs? Let's see. Professor Newman very astutely answering the questions in the chat. Thank you very much. Okay, so we will move to opioids then. Opioids. So we've covered this last semester in the substance abuse unit. But just as a reminder, we have a class of drugs which can either be natural, semi-synthetic, or synthetic. Natural opioids are derived from the poppy plant, as you see there. You can get codeine from poppy. And for those of you who enjoyed poppy seed bagels, my advice is not to submit for drug testing because you will have measurable levels of codeine and its metabolite morphine with the consumption of too much poppy seeds. Because that, of course, is where your naturally occurring opioids come from. Semi-synthetic basically are derived from codeine and morphine. So they're made in the lab, but from the natural precursor. And then fully synthetic are kind of your designer opioids, fentanyls, and those agents, which are basically fully synthetic. They're just made in the lab, not from a natural precursor. So basically, you have an endogenous opioid system. All right, you have chemicals in your body that circulate that will activate one of 3 types of opioid receptors. The common nomenclature is mu, kappa, and delta, the Greek letters, mu, kappa, delta. You may also see kind of in the pharmacology literature OP1, OP2, and OP3 that correspond to mu, kappa, delta. That's the newer nomenclature. I don't think it's caught on. We still refer to mu, kappa, and delta opioid receptors. But basically, your endogenous opioids consists of the enkephalins, the beta endorphins, and the dynorphins. And these are basically naturally occurring chemicals that will suppress the pain response. So they inhibit the ascending pathway for pain and can produce kind of euphoric effects. The classical example is marathon runners who exhibit that runner's high that will kind of block kind of the pain from distance running and allow that person to continue to push through to complete their marathons. So that is kind of an endorphin rush you kind of get. It's a analgesic and a pleasurable effect you get. And obviously this effect is exaggerated in the setting of substance abuse. So if you're shooting heroin, you get a much, much stronger high than you would with your naturally occurring or your endogenous opioids. Opioids are reserved for moderate to severe pain. Most cases of mild pain we manage with NSAIDs and acetaminophen, but because of the greater abuse potential for opioids and, frankly, their greater potency for pain, we reserve them for moderate severe pain. Question?
Yeah, I'm going back to that graphic one more time, sorry. That had the ascending and descending pathways.
Okay.
And I know there was enkephalin acting on the whatever STT neuron is, but I also see that there's serotonin and norepinephrine.
Yes.
Are those just other neurotransmitters that act on this pain pathway as well?
Yes, and they're going to be relevant when we talk about neuropathic pain. All right, so that would be a tricyclic antidepressants and other drugs that, a duloxetine, those agents, which I'll touch on later on. But yes, serotonin, norepinephrine, we take advantage of that pharmacologically, more so for chronic neuropathic pain.
Okay.
All right. All right, so for the opioids, here are the receptor types. Now, there's definitely a lot of overlap. So most of our drugs target the mu opioid receptor. It obviously has a strong role for analgesia, but also can cause sedation, respiratory depression, some of the euphoric effects that you get, the constipation, slow GI motility, and antidiuresis. Okay, so again, we covered this a little bit last semester. These are all classically the adverse effects of opioids: sedation, respiratory depression, euphoria, constipation. So those all come from activation of the mu opioid receptor. Of the endogenous opioids, the endorphins have the highest affinity for mu receptors, and they cause that inhibitory effect on efferent transmission from the spinal cord. So that's how you get part of its analgesic effect. Also in the brain, in terms of processing pain, it has some inhibitory effects there as well. So kind of the euphoria you get from this is also kind of a way that you cognitively deal with pain. So you kind of push that pain back in the background because of how the opioids affect cortical processing of pain signals, right? So that's why the pleasurable effects of opioids are relevant as well for analgesia. Kappa, they are activated by the dynorphins. And kappa receptors also have analgesic effects, but they also tend to cause dysphoria and dissociative effects and diuresis, okay? So whereas opioid receptors cause antidiuresis, kappa receptors cause diuresis. So you see overlap in the analgesia, but kind of opposite effects in the case of diuresis. So it gets a little confusing. Really, I think just note that they all cause analgesia, and then just focus on the mu effects for pharmacologic interventions, then you'll be in good shape. The kappa and delta, yeah, they'll be there to confuse you a little bit, but the good news of it is that most of the pharmacology really targets mu and not kappa and delta. But I'm, presenting it for completeness, obviously. Delta is activated by enkephalins, also has analgesic effects, also tends to be proconvulsant. The delta is also responsible for some of the physical dependence and has some effects on immune function as well. All right, and again, here is the signaling arc from the peripheral nervous system to the brain. The opioids will hit the spinal cord in terms of blocking the signaling, both ascending and descending, and then affecting the cortical processing of brain and in the brain, so that you have more euphoric, kind of a more positive outlook so that you can, again, deal with the pain without being, having the dysphoria associated with it. So that is where the opioids exert their effects. When we talk about opioids, and way back to our first lecture of the year, there is a whole range from full agonist to antagonist. And the full agonist will be most effective for severe pain. We talked about partial agonists, in particular buprenorphine, that have a ceiling effect. We use buprenorphine as an analgesic, but we talked about it last semester as well in the context of treatment of opioid use disorder. And then the full antagonists, they reverse the action of opioids. And again, they have a very strong use in the case of opioid overdose. So one of the learning objectives is to be familiar with the antidotes to opioid overdose, and of course the naloxone. We talked about that as a drug that can be given IV or, remember, intranasal, right? For patients with opioid overdose, that will very rapidly displace opioids from their receptors, causing people to wake up from a coma if the coma has been caused by an opioid overdose. Naltrexone is basically an oral version of that drug. When taken regularly, will kind of antagonize those opioid drugs that you may try to take on top of that. Here are the class effects of opioid receptors. Again, the drugs will mostly affect the mu receptor. Therefore, in the central nervous system, number one effect, of course, is analgesia. That's what we want. Euphoria, to a lesser degree, is what we want because, again, cognitive processing of pain, especially chronic pain, is part of that. We don't want just the analgesia. We want kind of the ability to function and to have a good outlook. So the euphoria is good, is helpful there. Cough suppression, we take advantage of that. Way back again from the first week of class, cough and cold, dextromethorphan and codeine are drugs that block that cough reflex. Again, that's an opioid effect. And then most of the rest of these are from toxicity and really unwanted effects. Meiosis, physical dependence, respiratory depression, sedation. You can get hypothermia from activation of mu receptors, but then kappa can cause hyperthermia. So really the body temperature is really not a great thing to go by because both the mu and kappa receptors have opposing effects there. Cardiovascular wise, vasodilation, hypotension, and bradycardia. Of course, the GI constipation is the big one, nausea, vomiting. You can get urinary retention and diuresis. So again, opposing effects there. And then the dermal effects. There is a flushing reaction that is not necessarily indicative of a full allergy. And then you can get a more IgE mediated allergic reaction with more systemic pruritus urticaria. So we'll talk about the distinction between those in a few minutes. All right. Chemical classes of opioids. I don't want you to get too hung up here, but this is going to be relevant when it comes to cross tolerance of opioids when we talk about, like, say, opioid conversions. And for those who have true allergies, especially to these opioids, going to drugs with different structures may actually help us manage pain in those, for example, with a true hydromorphone allergy or true codeine allergy. And again, I use the term true allergy intentionally here because there are some patients who report allergies to these drugs that do not have a true allergy. And again, I'll touch more on that in a minute. But the phenanthrene agents, basically a phenanthrene is a three benzene ring base, and then again have various functional groups that kind of project from that. This diagram depicts morphine, okay? And morphine basically will be this backbone, various modifications to this backbone will lead to some of these other drugs. Heroin, for example, takes this morphine backbone and puts an acetyl group here and here. That's called diacetyl morphine. And what heroin does is give it a very, very lipophilic property that gets into the brain very quickly, which makes heroin obviously a really nasty drug of abuse when given via IV or snorting. All right. Codeine is again a derivative of morphine, and hydrocodone, morphine, and so on. Again, recall that naloxone is an antagonist. All right. So an antagonist will often look the same, except will have some bulky side chain on the structure that will prevent it from activating the receptor. And that's definitely the case with naloxone. Basically has a side chain on it that will still have this backbone, but with the side chain not allow it to serve as a full agonist. In fact, it blocks the receptor. All right. So those are the phenanthrenes. When we go outside of this grouping, you get less cross sensitivity in those who have allergies. So the benzomorphans, loperamide is not a full agonist. This is a drug we use for diarrhea, right? This was one of the anti-diarrheas we talked about. Brand name of loperamide is Imodium, right? Diphenoxylate we also use for GI, like a GI antispasmodic, and pentazocine is a very wimpy analgesic drug. So these benzomorphans, again, slightly different in structure, but they're considered opioid agonists to some degree. Phenylpipridines. Again, as we go away from the phenanthrenes, they become less recognizable from this typical structure. And here, fentanyl is the prototype. Fentanyl is generally one of the safer drugs to give in those who have an allergy to most of these phenanthrenes. Very little cross-sensitivity. So fentanyl is a good option. But of course, fentanyl has a very bad reputation, of course, as being one of the key adulterants to heroin. And in fact, fentanyl is super, super, super potent. Small amounts of fentanyl that are added to drugs of abuse like heroin makes it so much more deadly. There are cousins of fentanyl, such as alfentanil or remifentanil, that's used in surgical settings. And then meperidine, which should not be used as an analgesic, we use it for surgical rigors or chills in patients who are post-op. So that's a phenylpipridine. Diphenylheptanes, again, we're going further away from the recognizable structures. Methadone is the prototype. Methadone, of course, is a drug we talked about last semester for opioid use disorder, chronic methadone maintenance. And then finally, phenylpropanol tramadol, and tapentadol. So these chemical groupings, again, just gives you a sense of where these drugs fall in terms of their cross-reactivity to morphine and hydromorphone. All right? And beyond that, I don't want you to get too hung up with that. Just note that these are the phenanthrenes, and the non-phenanthrenes are generally safer to give in those with allergies. That's really the take home here. All right? All right, let's go through, quickly go through the drugs individually, or the key points on these, starting with codeine. Codeine, again, is the chemical found in the poppy plant. All right, so that is a naturally occurring opioid. Codeine is converted to the much more potent morphine via CYP2D6. All right. Codeine is technically not a prodrug because it itself exerts effects on the opioid receptor, but in a lot of ways it might as well be because the drug that it's metabolized to is, again, much more potent as an opioid agonist. Now, the CYP2D6, this comes up time and time again as we go through pharmacology. This is an enzyme that is subject to genetic polymorphism. You have your fast metabolizers and your poor metabolizers. If you give codeine to a poor metabolizer, they have a much less potent or much lower ability to convert codeine to the much more active morphine. What that means is that it will be less effective as an analgesic and actually more toxic as kind of a GI irritant, all right? Conversely, you have CYP2D6 ultra rapid metabolizers, which will take this codeine and so readily convert it into morphine that it becomes super toxic relative to the general population. So, patients who are rapid metabolizers will rapidly convert codeine into morphine and get much more of the morphine toxicities of respiratory depression, etc., constipation, etc. Whereas the slow metabolizers will take codeine and not as readily convert it into morphine there and with that morphine being a more potent agent, not get the same benefit as you would normally and actually get more of the codeine toxicity. So with all that, I'm not a big fan of codeine. We should not be using it too often for analgesia. It's okay as a cough suppressant in some of these cough syrups like Phenergan with codeine or whatever. At low doses as a cough suppressant, it's okay. We really should not be using a lot of Tylenol number 3 for pain, especially if we don't know whether the patient is a rapid or poor metabolizer. It is a controlled substance, as are all the opioid agonists. In the case of codeine, it's either a C5 or a C3, depending on what formulation is being administered. Hydrocodone is basically a derivative of codeine that actually is typically found as a combination with acetaminophen. So Lortab or Norco are basically oral drugs that combine acetaminophen with hydrocodone. This is a good short-term pain analgesic, not as problematic in terms of its metabolism pathway, although it does rely on 2D6. But hydrocodone as a parent drug is effective enough as an analgesic that does not have the same GI issues as with codeine. So, we're not as concerned about the slow metabolism of 2D6. Hydrocodone products, we used to think have a lower abuse potential, but since the current opioid crisis has settled in, the federal government had rescheduled this as a C2. So your Lortabs are now have the highest level of restriction for controlled substances. Morphine. Morphine is one of our kind of go-to agents, one of our most potent opioid agonists. It is often used in institutional settings as IV pain management, and then can be used in chronic pain with long-acting oral formulations as well as short-acting formulations for breakthrough pain. It is metabolized via glucuronidation at the 3 and 6 positions, and its metabolites are renally cleared. So we do have some concerns around morphine in those with renal failure because the accumulation of those metabolites can lead to more CNS suppression. And morphine can trigger histamine release. Again, just the histamine release does not represent an allergic reaction, but can lead to kind of a pruritus and those sorts of swelling, edema, those sorts of effects from just the histamine release alone, not a full-blown IgE-mediated allergy. Oxycodone is present in OxyContin, which is a notorious drug. Of course, if you've been following Purdue and the Sackler family and how they marketed OxyContin as a safe opioid, and the liability now that family has both in federal and state-based cases for the opioid epidemic, really represents a really unfortunate story within the context of this ongoing opioid epidemic. But OxyContin is still a useful drug when prescribed appropriately for chronic pain. Short-acting oxycodone is present as well, both in standalone products and in combinations with acetaminophen. So you can see the long-acting formulations, 8 to 12-hour duration, typically given twice a day. Short-acting can be given every 4 to 6 hours for breakthrough pain, and it's also a 2D6 substrate. Hydromorphone dilaudid, another drug we give mostly for chronic pain and acute pain in inpatients. You see that it's it's metabolized via glucuronidation, fairly short half-life. In surgical settings, you'll see anesthesiologists give microdoses every, say, 10 to 15 minutes based on the patient's pain response. And some people will report less pruritus with hydromorphone compared to morphine, but N01 of my wife, she seems to be much more sensitive to the hydromorphone than morphine. So, your mileage may vary with the histamine reactions. And then there's fentanyl. Again, fentanyl is another unfortunate anecdote in this whole opioid crisis, but things to know about it is that it is 100 times more potent than morphine. We measure fentanyl doses in micrograms, not milligrams, and it is given IV typically for patients who have either an allergy to the phenanthrene-based opioids, or who may have developed some tolerance to those agents and might need to switch classes. There's also long-acting transdermal formulation called Duragesic, again, reserved for those with chronic pain management needs. It's provided as a patch that's given every 72 hours, a Duragesic patch. I have depicted here the oral transmucosal fentanyl citrate. It's basically a lollipop that is given and absorbed through the buccal membrane. So again, very lipophilic, very small molecule, crosses into the brain, just a kind of a designer opioid that kind of readily lends itself to transdermal as well as transmucosal administration. And in the surgical settings, you see some of its cousins, alfentanil, sufentanil, and remifentanil. We don't use this typically outside of those surgical settings. And again, because of its different chemical structure, the fentanyl has a role for those with allergies to the phenanthrenes. Meperidine, Demerol is also related to fentanyl in terms of its chemical structure, but we do not use it for analgesia. Meperidine has a role more so for writers, patients who experience chills in the surgical settings. The problem with meperidine is that it accumulates in renal failure. to a metabolite that can cause seizures. All right, so we avoid meperidine except for small doses in Rikers. And then there's methadone. We talked about this last semester. It is not just a drug we use for opioid use disorder. Some of your advanced pain management clinics have really taken a liking to methadone because not only does it activate mu, kappa, and delta receptors, but also has some effects on the NMDA receptor, the norepinephrine and serotonin pathways as well. So you have multiple mechanisms in which it can exert some analgesia, and that will make it helpful for those who maybe fail some other opioids. Again, methadone is still a long-acting drug, but despite its long half-life, we will often dose it every 3 to 4 hours, small amounts for pain. So really, its use for analgesia differs from its use in opioid use disorder. So when we're doing methadone maintenance, it's usually once a day, long half-life. But if we're treating breakthrough pain, it's often small doses every few hours because the acuity for the pain, its effects are really the first few hours after dosing. We'll get into opioid conversions, but methadone does not lend itself well to some of the conversion method ratios because of its multiple effects on different receptors. Just as a reminder, methadone can prolong the QT interval and also has interactions with P450 inhibitors. Again, buprenorphine, another drug you should be familiar with last semester. Partial agonist, tight binding, and makes that helpful for opioid use disorder because of its tight binding to the receptor and its low signal transmission downstream. If you try to abuse opioids on top of it, you don't really get the euphoric effects, but at the same time, you do satisfy some of the withdrawal issues and physical and psychological dependence that you get from opioids. Tramadol. Again, if you look back to that slide with the various chemical classes, you see tramadol is kind of most dissimilar from the phenanthrene opioids. It's a weak mu agonist, but also takes advantage of serotonin, norepinephrine reuptake inhibition to provide additional analgesic effects. It was thought to have a lower abuse potential, but has in the last several years been rescheduled from being scheduled to a C4 controlled substance. All right, and you can see so some abuse potential with it. It also is co-formulated with acetaminophen in a product called Ultracet. So Ultram plus acetaminophen is Ultracet. And then related to that is tapentadol, is a drug we really use more for neuropathic pain because of its norepinephrine serotonin reuptake. It's more of a primary effect than with most of the other opioids. Tapentadol is scheduled as a Schedule II controlled substance. So those are the highlights in terms of the individual opioid drugs. Again, as a class, a lot of similarities in terms of pharmacologic and toxicologic effects. Constipation, you don't develop tolerance to. The longer you're on it, the constipation will always be there, all right? So you have to manage that. Some of the other effects, sedation, GI, nausea, vomiting, and then the histamine release, the pseudoallergy. Basically, you have some effects on immune mediators from the opioid, I believe, delta receptors, and that can lead to cutaneous reactions. Again, these are not full-blown IgE-mediated allergies, but you can get kind of the pruritus, the itchiness, a little bit of swelling. This is not going to progress into anaphylaxis or anything of that nature. You see it most frequently with codeine and morphine, and a lot of your patients will report codeine allergy, morphine allergy, really are just getting this histamine release. Does it mean that you should re-challenge them? No. I mean, this is not a comfortable effect to get, but at the same time, it does not represent a full-blown allergy. In those cases, you absolutely have to treat them with one of these drugs. You can co-administer an antihistamine such as Benadryl to manage that. Now, some of the less frequent effects, delirium, respiratory depression, really is seen much more often either with a drug interaction or toxicity, and of course the abuse and diversion risk. So the full true allergy is IgE mediated. To those who had a previous exposure, develop these antibodies, and then you re-challenge them. That, again, is not as common, but it can happen. You get hives, maculopapular rash, hypotension, bronchospasm, angioedema. This looks more like a full-blown allergic reaction. And in those cases, it's much more severe. You are talking about steroids as well as antihistamines. So we need to suppress the autoimmune response that happens in those cases. But again, most patients who have a so-called codeine allergy, it's usually just either GI intolerance or kind of the histamine-mediated cutaneous effects. All right, is that clear? So when using opioids, again, the first and foremost is reserve these drugs just for your moderate to severe pain. Don't want to give these out like candy. We've learned a lot of hard lessons from, how OxyContin was marketed and that sort of thing. Do not overprescribe them. There's all sorts of liability you'll run into by doing that. But assuming you have someone in whom opioids are appropriate, use gradual titration, get at some of the underlying causes of symptoms. If it's a, kind of a muscle spasm, there are safer drugs we'll talk about a little bit that can manage that. Or inflammatory mediated reactions, you can use anti-inflammatories like NSAIDs. Dosing route or regimen, there will be a need, for example, in many cases to convert from IV to PO. We'll talk about some of those conversions in a minute. Managing adverse effects, nausea with antiemetics, cutaneous reactions with antihistamines, and then constipation has to be kind of more aggressively managed, especially if you'll be using opioids chronically. Really, the classic approach is to use a bowel regimen that consists of a stimulant and a stool softener. What the opioids do is both inhibit the peristalsis, the movement through the large intestine, as well as the secretion. So the stimulant plus stool softener combinations, Senna plus Docusate, Senocot S, is great for that. Then using Miralax. The other kind of more expensive, more sophisticated approach is to use the peripheral opioid antagonists. These agents will block the effects on mu receptors in the bowel without getting into the CNS or spinal cord. So you preserve the analgesic effect of the opioids without causing the peripherally mediated constipation. We talked about these drugs briefly last semester: methyl naltrexone, Relistor, naloxegol, or now memedine. So these are opioid antagonists that work selectively in the large intestine. Used for chronic opioid exposure to prevent constipation. And then in the case of overdose or toxicity, the opioid antagonists are the way to go. Naloxone, of course, again, we can give IV or intranasal. Has a very fast onset. The one thing I do advise you of is if they have an overdose involving a long-acting opioid, right? Say they take a lot of OxyContin PO that has, say, an 8 to 12 hour duration. You give this naloxone, they will wake up pretty quickly, but typically the opioid antagonist will wear off before the opioid agonist, so they may slip back into a coma after they wake up because the Narcan has a very fast onset and fast elimination. So that can be a scenario you encounter. Here are some guidelines on selection of opioids. It's going to be based on the pain intensity, pharmacologic factors like history of allergy, that sort of thing. And in your chronic pain management patients, you will often have a ongoing basal regimen that consists of a long-acting opioid with short-acting opioid and opioid combinations for breakthrough. Oral administration is generally preferred. We do have patches and other extended release oral formulations for longer acting effects. And start low and go slow. Really, that's a good thing to preach for many conditions, definitely for opioids, because you can always give more, especially if you're treating an inpatient. But once it's on board, it's hard to take it back. I mean, certainly you can reverse those effects, but then it gets really messy with kind of chasing after opioid overdoses and pain management. So kind of get a good sense of how much opioid it requires to manage that patient's pain. And then we will do calculations to take that daily dose and convert it to a long-acting regimen. The other approach is to use a PCA. I'm sure many of you have heard of these. This is called patient-controlled analgesia. This is basically a kit that involves a solution with an opioid that may or may not be infused on a basal regimen, meaning kind of a continuous infusion. But there's also a button that the patient will be able to give a bolus of the opioid. So that additional medication can be controlled by the patient in the event of a breakthrough pain that the patient is being administered. So you have both the on-demand dosing plus or minus the basal continuous infusion. As a provider, you will need to write for the basal rate, if it's applicable, the dose that is given on a demand basis, and then something called a lockout interval. So it does not allow for unfettered patient dosing, meaning that you can't just allow the patient, free, continuous on-demand dosing as much as they want. The lockout interval basically establishes a period of time between which patients cannot repeat that on-demand dose. All right, so that's usually in minutes. And then total amount allowed during a time period. So typically the on-demand dose is about 1/4 to 1/3 of the basal rate. And then, after you get the patient on a PCA for several hours or days, you can make adjustments to the basal rate based on their actual usage. So, for example, if you are starting someone that comes out of a surgery on a morphine PCA, you will write for the basal rate, for example, 2 milligrams of morphine per hour. That is going to be infused on a continuous basis from that syringe, 2 milligrams an hour. The demand dose is basically going to be what the patient gets when they hit that button. In this example, it'll be a 0.5 milligram of morphine. The lockout interval is how long in between the demand doses that can be administered by the patient. So if they hit the button, they get a 0.5 milligram of morphine, and they will not be able to redose themselves for 15 minutes. A lockout interval of 15 minutes means that they can get no more than 4 doses an hour, right? It's 15 minutes. If they do it exactly every 15 minutes, you end up giving 4 doses, 0, 15, 30, and 45 minutes in a 1 hour period. So if you wanted to figure out what is the maximum amount that patient can get in 4 hours, well, you take this basal rate of 2 milligrams an hour times 4. You take the maximum of 4 doses an hour times 0.5, and then multiply that by 4 hours, and you would get 16 milligrams. All right, so 2 milligrams an hour times 4 hours, and then 0.5 times 4 doses times 4 hours, that comes out to 16. All right. So they end up getting maximum 16 milligrams of morphine every 4 hours. Then you can extrapolate that into a daily dose of morphine or what have you. This is going to be variable based on how much demand dosing that the patient administers. If they end up not needing it every 15 minutes, then this 4 doses an hour will be less. But with a 15-minute lockout, they can get no more than 4 doses an hour. All right, and then we get more fun with math, and that is with opioid conversions. What do you do when you want to get someone either off of an IV regimen to a PO or switch from one opioid to another? This will occur in the event of lack of efficacy, poor tolerance, formulary issues, allergy issues, what have you. And this will basically look at what the patient has been getting, converting it to a standard, which is usually morphine, and then converting that to this new drug that you want to administer. There is a fudge factor, 55 to 75%, which is due to what's called incomplete cross tolerance. When you switch from one opioid to another, you do have to account for the fact that that second opioid is going to end up being a little bit more potent right off the bat because of what's called incomplete cross tolerance. So there are resources on this in drug references that will give you these conversion ratios. Really, the first step will typically be taking whatever regimen they are on and converting it to morphine. Morphine is kind of that standard drug from which everything else kind of comes from. So, for example, the oxycodone to morphine ratio is listed here, 1.5 to 1. Hydromorphone, 5 to 1. And basically converting to morphine is typically the first step. So we'll kind of walk through an example. In the Blackboard folder for this pharmacology lecture is a more in-depth presentation from one of my colleagues, Dr. Lynn McPherson, who has a specialty in this area of palliative care. And it will be very helpful to kind of practice. And there are additional resources that I'll be sharing with you as well. But we'll run through this example really quickly in the interest of time. You have a terminally ill lung cancer patient. They're on hydromorphone, 4 milligrams Q6, and we want to convert it to an equal analgesic dose of long-acting oxycodone. So you take this 4 milligrams Q6, you get the total daily dose. All right, Q6 hours means they get it 4 times a day. 4 times 4 is 16 milligrams of hydromorphone. Now, the hydromorphone needs to be converted to morphine. That is going to be that first step of conversion. The ratio is 5-1. So you take 16 times 5 gets you 80. And then the PO to IV conversion is double, a factor of 2. So 80 times 2 is 160. So that is the oral morphine. Now, the oral morphine to oral oxycodone is a 1.5 ratio, so that gets you down to 107 of PO oxycodone. And then we have to account for this fudge factor, 30 to 50% due to increased cross tolerance. I'm just taking the average 0.4, 40%, and that gets you down to 64. And then we need to do it in terms of a kind of a pharmaceutically available formulation. So instead of 64 a day, we round it to 60 a day, OxyContin, 30 milligrams BID. All right. That's kind of the quick and dirty. I'll take some questions on this with the understanding that you might not have absorbed everything really quick, and give you an opportunity after class to kind of look at the McPherson presentation that will also talk you through it. Aaron, do you want to ask a question?
Yeah, it's just a quick question. Where on the chart are you getting the 5-1? Because I only see the morphine to the hydromorphine 5-1. Is that what you were referencing?
Yeah, so this is the parenteral morphine to other opioids. All right, so that's the 5-1. That's here. And then the oral morphine to parenteral morphine is the 2-1. That's here. And then the morphine to oxycodone is 1.5-1 here. All right, so that's kind of where you go through that process. Certainly on an exam, I will provide those ratios. You're not expected to memorize them, but we will revisit this. I will either, prior to the exam, kind of walk you through other examples of this. But, I just want to get through today's content and give you a chance to view the other slide presentation that goes a little more in depth on it, give you some chance to practice on it, and then we'll talk more about it prior to your exam, just so you make sure you have it down pat. All right. But that's just the general process. All right. So in the last few minutes, we'll cover the adjunctive pain medications. Fortunately, a lot of these we've talked about in other contexts. First of all, the neuropathic pain. This is seen in various syndromes such as diabetic peripheral neuropathy, trigeminal neuralgia, postherpetic neuralgia. And really our management strategies involve drugs that either work through serotonin or epinephrine, such as tricyclic antidepressants and SNRIs, as well as the drugs that work on the neuronal transmission, such as anticonvulsants and lidocaine. So here are the anti-epileptics. The ones that are great for neuropathic pain: gabapentin, pregabalin, work through NMDA and calcium channels. We talked about that with seizure drugs last semester. Carbamazepine also has a role by blocking sodium and NMDA. So you'll see carbamazepine for the trigeminal neuralgia. It's a drug of choice for that. Gabapentin, pregabalin is great for diabetic neuropathy, postherpetic neuropathy, and fibromyalgia syndrome. The antidepressants work through the serotonin or epinephrine. Remember, they also contribute to that spinal transmission of pain. So basically, by inhibiting the reuptake, you increase the availability of serotonin or epinephrine. You see that with the TCAs. Usually low doses are sufficient: amitriptyline, desipramine, and your SNRIs such as duloxetine and milnacipran, which is used for fibromyalgia. Duloxetine is a great drug as well for diabetic neuropathy. You'll see local anesthetics used. There is lidocaine, which is available as a topical like cream or jelly, as well as a patch. We'll talk a lot more about lidocaine, its role in anesthesia, in your surgical unit later this semester, but here, just kind of a numbing effect that you get from the lidocaine patch and lidocaine creams by blocking neuronal sodium channels. Capsaicin is a topical that we use that works through substance P. Again, think back to the beginning of the lecture. I said that substance P is part of that inflammatory cascade, and that will be depleted with the use of capsaicin. By depleting substance P, that you are reducing one of the inputs into the pain response. Capsaicin is derived from chili peppers. So you kind of get a burning sensation initially, but as substance P gets depleted, it becomes kind of an analgesic response. And you need to advise your patients to wash your hands after, using it and spreading it on their body so that you don't kind of get that persistent burning effect unwittingly on your hands. And then there are the skeletal muscle relaxants. These are agents used for muscle spasms. They work through a number of mechanisms. I will present them based on their mechanism, but really those distinctions don't matter too much clinically. They all kind of help for muscle spasms that you get from skeletal muscle injuries. So the antispasmodics work in the brainstem. They include cyclobenzaprine flexeril, carisoprodol soma, metaxalone, and methocarbamol. So again, if you have a patient with painful muscle spasms and you want to avoid opioids, maybe using the muscle spasm as a antispasmodic muscle relaxant is a better way to tackle that compared to the opioids. Baclofen works at GABA receptors, and that will also tend to relax the muscles. There is an intrathecal version of this agent that's administered in the spinal cord for surgical patients. Other GABA inhibitors, such as benzodiazepines, also exert potent muscle relaxation effects, so that's good to know as well, like diazepam. Tizanidine works as a alpha-2 agonist. Remember, clonidine is an alpha-2 agonist we talked about for blood pressure, ADHD. Basically, tizanidine works through the same mechanism, but has much more selective effects on spinal cord transmission compared to, vascular effects on blood pressure. And then finally, dantrolene is a direct-acting skeletal muscle relaxant, which basically depletes prevents the release of calcium from the sarcoplasmic reticulum so that you get less of the coupling that leads to muscle spasms. So, they're different mechanisms. They all achieve the same effect of basically preventing spasms, preventing kind of unwanted contraction of muscles, either directly in effects of dantrolene and indirectly through the brainstem and alpha effects and GABA effects with the other agents, right? And these are good ways to spare opioids. All right. So that is where I'll conclude. I'll take any additional questions. There are additional slides at the end of the presentation for you to read on your own that really gets a little bit more into the clinical use, especially of opioids. You can review those on your own. Questions, comments? Professor Newman, I think you were first.
My question's kind of interesting in that, that last drug that you put up there, dantrolene, with the calcium blockade, essentially from the sarcoplasmic reticulum, is it specific to skeletal muscle?
Yes.
So it will not affect cardiac muscle.
And yeah, so there are, I don't get into the weeds too much,
I
but
was just curious.
there are two different, um, 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 channels, ion channels that calcium are affected in. Skeletal muscle has one type, and cardiac and smooth muscle has the other type. Dantrolene is specific for the channels in skeletal muscle, thereby causing skeletal muscle relaxation without affecting, say,
Cardiac conduction.
peristalsis and cardiac contraction and all that. So yeah, it's a specific direct acting skeletal muscle relaxant.
Thank you. That's
Mhm.
interesting.
Yep. I think you're next, Abel.
Yeah, so real quick for the opioid conversion
Yes.
and kind of for test purposes and stuff.
Sure.
The reduction for incomplete cross tolerance.
Tolerance.
Should we be able to recognize which ones are completely cross tolerant? Are there any that are completely cross tolerant?
No.
Okay.
If you're going from one drug to another, okay, not from say IV to PO within the same drug. So you don't do that factor reduction from say IV morphine to PO morphine. But if you're going from morphine to any other opioid, okay, we do utilize that factor. All right. It doesn't matter if it's to fentanyl or if it's to another kind of phenanthrene. All right. So it's that kind of 30 to 50%. I think the good approach is to just kind of use the 40%, which is right in the middle, because you're going to end up rounding it off to a commercially available product anyway. So if you end up with, say, like in the example, 67 milligrams of oxycodone, you're going to end up rounding that off to 60 or 70 or whatever anyway. So, it's just a fudge factor. You may end up getting to a dose and then maybe having to titrate up or down anyway based on the patient's individual factors. But yeah, that applies for when you're going from one opioid to any other opioid that's just a different generic product.
Okay, thank you.
Mm-hmm. All right, Aaron, I think you're next. You have to unmute.
Can you hear me now?
Yes, I can.
There are a couple objective questions that just ask us to identify the treatment options for the acute versus chronic and then the nociceptive versus neuropathic pain. And there were a couple slides, I think the WHO analgesic ladder, etiology-based treatment. Can those serve, do you recommend using those as kind of a guide to help see the overall bigger picture? And
yeah, so those are more for bigger picture. The nociceptive pain is going to be basically all the opioids, all the NSAIDs, and skeletal muscle relaxants. And then the neuropathic pain are specifically these drugs, the anti-epileptics, antidepressants, and local anesthetics used for those neuropathic pain conditions, diabetic neuropathy, postherpetic neuralgia, those sorts of specific conditions which seem to respond a lot better to drugs that affect the nerve transmission more so than anti-inflammatories and opioids. All right, so again, think of a multiple choice exam. If you're given one drug that works for neuropathic pain and the others are anti-inflammatories and opioids, basically you have to be able to select which one is most appropriate for neuropathic pain. There'll only be one best answer there. Did I get at your question? What was the other objective you wanted to ask about?
Oh, there were two questions, but we're along that same theme. So that answered both of those.
Okay, great. Thank you.
Ryan, did Dr. Noel's answer to Abel's question satisfy your question in the chat?
Yes, that's exactly what I was wondering. Thank you.
All right, lovely. Hopefully we will get some melting of snow before, actually there'll be more snow and then hopefully more melting next week. And we could meet in person again. All right. All right, thank you, everyone.